So hi everyone, I'm Neel. For those of you who don't know me, I'm one of the second year fellows. I'm going to be doing fetal therapy today on cystic fibrosis and pregnancy. This would be kind of a good topic to review, one, because we had a patient who came to us last week for consult who had cystic fibrosis and was pregnant, and also there's been some major advances in the treatment of cystic fibrosis in the past 5 years or so. So I think we're going to be seeing a lot more of this in the next couple of years. So just start with our case. Our patient was JRR. She was a 41-year-old G2P0. She's at 9 weeks and 3 days by an 8-week ultrasound when she came to us for a consult last week. Her past medical history was significant for cystic fibrosis, pancreatic insufficiency, anxiety, and iron deficiency anemia. She never had any surgeries, one prior miscarriage at 6 weeks, about a year before this pregnancy. Otherwise, no significant obstetrical or GYN history. She was on Trikafta, Pulmozyme, Creon, and vitamin D, and then Zoloft for her anxiety. And she followed closely with pulmonology here at Jefferson, and then of note, she had Ashkenazi Jewish heritage. So just a little review, kind of back to med school. Cystic fibrosis is caused by a mutation in the CF transmembrane conductase regulator gene, which is on chromosome 7, and that gene encodes for a channel protein that transports negatively charged chloride ion in and out of the cells. It assists with movement of water into tissues, and so it allows for the production of a thin, free-flowing mucus. And so it's involved in mucus, sweat, saliva, tears, and the development of digestive enzymes. It affects about 80,000 people worldwide, and about 35,000 people here in the US alone. And in the US, the prevalence varies greatly by race. So it's most prevalent, again, among white Americans, about 1 in 3,000, about 1 in 10,000 for Hispanic and Native Americans, 1 in 15,000 for Black Americans, and then 1 in 30,000 for Asian Americans. There's increasing prevalence estimates worldwide, primarily in Latin America, Africa, and Southeast Asia. It's likely due to increasing recognition of the disease in these populations, kind of more widespread newborn screening, and then recognition of individuals who have mild disease or disease that's limited to a single organ system. And thinking about the genetics, it is an autosomal recessive disease. There are more than 2,000 different mutations in the CFTR gene that can cause disease. The most common is the F508 deletion, results in the deletion of 3 DNA base pairs that are coded on the 508th amino acid residue, which typically would code for phenylalanine. At least one copy of this mutation is found in about 90% of individuals with CF, and about 50% are homozygotes for this. There's actually 5 different classes of CFTR disease-causing mutations. So class 1 would be defects in protein production. These are typically like non-sense or splice mutations. They produce kind of no functional CFTR protein. Class 2, which is the most common, and where that F508 deletion is, its CFTR protein is produced but kind of misfolds in its transport from the ribosome to the cell surface. Class 3 is defective regulation, so the channel gates don't open properly. Class 4 is the channel doesn't function properly, and then class 5 is there's just a absolute decrease in the amount of CFTR protein in the cell. So classes 1 through 3 are kind of the most severe disease. Like I said, class 2 is the most common. As we know, ACOG kind of recommends carrier screening for all pregnant women at some point in their life. And this is typically via a standard panel of the 25 most common CFTR mutations. Unfortunately, the standard panel kind of has varying rates of detection of the mutation based off of ethnicity. So it can detect about 94% of CFTR mutations in Ashkenazi Jewish patients, and nearly 90% in non-Hispanic whites. Kind of the yield is much lower in other races, so only about 64% in African Americans and only about 49% in Asian Americans. There are expanded carrier panels that are kind of available for non-Hispanic white patients. It's difficult to kind of determine which CF mutations to add to the standard panel because CF mutations in these populations are typically, the frequencies aren't kind of very well known. And so the commercially available patent ethnic panels may not have a higher sensitivity than the standard panel. And it may include mutations that have like unclear clinical significance, which makes it difficult to predict the phenotype in offspring that may be affected. There's also CFTR sequencing, so it's typically not appropriate or recommended for routine carrier screening. This is recommended for patients who like may have CF or be a CF carrier and their partner's getting tested. So that's what our patient did. Her partner had CFTR sequencing and he did not carry any CFTR mutations. And then now in the US, we have universal neonatal screening. It's typically like a two-part stepwise testing. The first is a serum immunoreactive trypsinogen level, and if that's elevated, then they'll move on to DNA analysis of mutations in the CFTR gene. And how do we diagnose CF? So in the past, most patients were diagnosed with CF after presenting with the symptoms. However, because of the expansion of newborn screening during the past 20 years, there's been a dramatic increase in the number of CF cases identified before presenting with symptoms. So in 2001, where we didn't really have universal newborn screening, fewer than 10% of CF cases were diagnosed in asymptomatic individuals. By 2021, about 65% of newborn CF cases and about 95% of all diagnoses were made before the age of 6 months, and they're detected by the newborn screen. And there's lots of evidence that individuals diagnosed prior to the onset of symptoms have better lung function, better neurocognitive outcomes later on in life, and better nutritional outcomes, as well as less likely to utilize the healthcare system. So to diagnose it, you kind of need one clinical symptom and one lab criteria. The clinical symptoms are kind of phenotypic symptoms, so chronic lung disease, chronic sinusitis, GI nutritional abnormalities, salt loss syndrome, or obstructive azoospermia in a male. You can have a history of a CF in a sibling or a positive newborn screen. And then the lab criteria, the one that we all probably remember, is the elevated sweat chloride concentration, which is where they'll put an electrode on the patient's arm. The electrode will drive medication into the skin, and then they'll put a filter paper on the skin to collect sweat. And if there's elevated chloride within that sweat greater than 60 millimoles per liter, that's diagnostic. We can also get gene sequencing, and if you have two mutations in the CFTR gene that are known to cause CF, that's diagnostic. Or you can look at the nasal potential difference, which measures abnormalities in ion transport across the nasal epithelium, and that can be diagnostic as well. And so just thinking about kind of the symptoms and the organ systems that are affected by CF, the most common presenting symptoms are meconium ileus. This is usually going to present by 2 weeks of life. Respiratory symptoms will typically present within the first year of life as well. And then many infants will present with failure to thrive because of the pancreatic insufficiency. There's also CFTR-related disorders. So this is when CFTR is only affected in one specific organ system. So certainly many men will present with like azoospermia and then be diagnosed based off of that. And then in infants, there's CFTR-related metabolic syndrome, which is where it's asymptomatic infants who had a positive newborn screen and kind of intermediate sweat chloride result. And so these patients, it's difficult to predict the clinical course. They need to be followed very closely. And then very rarely is it diagnosed in adulthood, 5 to 7% of cases, and they'll typically present with milder symptoms like GI symptoms, male infertility, diabetes, and they'll have normal pancreatic function. Their sweat chloride test will be equivocal, and then they typically will present with kind of rare genetic mutations in the CFTR gene. The most common symptom that we see with CF are respiratory tract involvement. So they're going to have a productive cough, hyperinflation of the lung fields on chest x-ray, pulmonary function tests that are consistent with obstructive airway disease, which include increased residual volume to total lung capacity. The disease progression is evident with decreasing forced expiratory velocity at 1 second, which is kind of how they monitor disease progression in CF patients. You can also develop chronic bronchitis with typical organisms. So in infancy, Most of these infants will develop bronchitis related to Staph aureus. That kind of prevails for most of infancy and adolescence. During adolescence, Haemophilus prevalence increases, and then in adulthood, the majority of patients will get Pseudomonas or maybe colonized with Pseudomonas. And then kind of the pathology of this is kind of the repeat infectious causes bronchial wall damage, loss of cardiac support and muscle tone in the lungs, which eventually leads to bronchiectasis and eventually may require lung transplantation. You can also have sinus involvement. So 90% of CF patients will develop nasal polyps secondary to chronic rhinosinusitis, and this will present as chronic nasal congestion, headaches, sleep disturbances, postnasal drip that can trigger lower respiratory tract infections. The prevalence of sinusitis has significantly decreased since the development of the CFTR modulators, which we're going to talk about in a little bit. And then pancreatic disease is also pretty widespread in CF patients, so it's present at birth in about 85% of infants born with CF. An additional 20 to 25% will develop pancreatic insufficiency during the first several years of life. This is diagnosed with a fecal elastase level less than 200 micrograms per gram, and they're typically going to present with failure to thrive, poor weight gain, steatorrhea. They'll require lifelong pancreatic enzyme replacement and fat-soluble vitamin supplementation, and then you can use that fetal elastase to kind of measure their exocrine pancreas function throughout their life. For patients who have pancreatic sufficiency, about 10% will develop pancreatitis, which is because of defective pancreatic secretions that cause progressive pancreatic damage. And then about 25% of individuals will develop cystic fibrosis-related diabetes by age 20. And this is managed kind of as normal diabetes. It typically presents as like a mix of type 1 and type 2, so they often need insulin. Like I said, a lot of infants will present with meconium ileus later on in life. These individuals are at increased risk for intestinal disease, so this typically presents as a distal intestinal obstruction. It's more prevalent among patients in those class 1 through 3 mutations. There are increased risk for gastroparesis, and risk factors for intestinal disease are if they have pancreatic insufficiency, they have issues with chronic dehydration, they previously had meconium ileus as a child, and if they have diabetes or eventually require organ transplantation. And treatment usually involves osmotic laxatives and may even require manual disinfection. And about 50% of adults will eventually develop this. And they're also at an increased risk for musculoskeletal disorders because of their reduced bone mineral content. About 75% will develop decreased bone mineral density by adulthood. There's increased risk of fractures and scoliosis, and this is multifactorial in origin. One, because they have malabsorption of vitamin D. They have poor nutritional status throughout their lives, and they're physically inactive because of their lung disease, and then many of them previously were on chronic steroid use, which increases this risk. And patients with that F508 deletion are particularly susceptible to decreased bone mineral density. There are also increased risk for anemia, particularly iron deficiency anemia, because of decreased iron absorption, as well as many will develop anemia of chronic disease because of the lung disease that they develop. And then there's increased risk for electrolyte abnormalities, particularly because of the excess loss of sodium and chloride in sweat. And then important for us, about 95% of men with CF are infertile because of defective sperm transport, and this is typically because of the absence of vas efferents in them. They can help their partner get pregnant if they want. Their sperm is still produced. They can get microsurgical epididymal sperm aspiration and eventually ICSI. Women with CF are found to be less fertile compared to the general population, so the risk or the rate of infertility and subfertility is about 35% in this group compared to about 10 to 15% in the general population. And this is thought to be due to chronic malnutrition. Like the thickened lung secretions, they also have thickened cervical mucus that's less hospitable to sperm. But thankfully, the CFTR modulators have been thought to increase fertility. In one study in the UK, there is a 50% increase in fertility after introduction of these medications. So that's a good transition to talking about treatment options for these patients. So the kind of primary medication that is on the market right now are CFTR modulators, And so prior to their development, kind of most of the therapies available for cystic fibrosis focused on symptom management and decreasing the downstream effects of CFTR dysregulation. Many often eventually required lung transplants. The first CFTR modulator was approved in 2012 by the FDA, ivacaftor, and currently on the market there's two types of CFTR modulators. There's potentiators like ivacaftor, which improve function of the CFTR protein at the cell surface, and then correctors, which aid in trafficking of CFTR to the cell surface after it's produced in the ribosome. There's a couple of new classes that are currently in clinical trials and under development. Amplifiers will increase the amount of CFTR mRNA, and ideally then increase the amount of CFTR protein. And the stabilizers will limit the removal and degradation of CFTR protein from the cell surface. And so all patients who have CF should undergo CFTR genotyping to determine if they carry a mutation that makes them eligible for CFTR modulator treatment. The most common med right now is Trikafta, which is 3 different CFTR modulators combined together. And at least most of the patients on this medication have at least one copy of that F508 deletion. Treatment obviously began in adulthood, but now treatment can be started as early as age 6. There's obviously different dosing for children than for adults. And the primary side effects of these medications are GI, upset, so diarrhea, nausea, as well as something that can cause a transaminitis. And the outcomes related to these medications have been pretty significant. So in the clinical trials when they were being studied, there was an immediate improvement in pulmonary function within 4 weeks of treatment. So in most of the studies, there was improvement in FEV1 by about 10%. Immediately after starting the medication. Among CF patients with advanced lung disease, there were decreased oxygen requirements as well. Now that they are more widespreadly used among children with cystic fibrosis, many studies are showing that they're preventing, delaying, and sometimes even reversing the pancreatic insufficiency when they're started in childhood, and they've even shown an improvement in pancreatic function among adults with CF. And probably the biggest thing related to the CFTR modulators is the huge increase in life expectancy. So in like 2010, 2012, when the medications were introduced, the life expectancy was about 48 years for the average CF patient. Now a baby born in the 2020s with CF, the average life expectancy is about 66 years, which is pretty amazing. In addition to the CFTR modulators, most patients are on pancreatic enzyme replacements. So our patient was on Creon, and these are typically extracts of porcine pancreas, and they contain various amounts of lipase, protease, and amylase. These are typically started in infancy at the first signs of pancreatic insufficiency, and the goal is to improve fecal fat absorption. Because they are enzymes, they have side effects like creating oral ulcers in the babies. For moms who are breastfeeding, there can be areolar excoriation and then perianal rash in infants. And patients will still require fat-soluble vitamin supplementation, which are A, D, E, and K. And there's a recommendation for annual vitamin level testing to make sure that they're getting enough supplementation. In terms of antibiotics, many will be on chronic antibiotics. So like I said, many patients will get Pseudomonas and may be colonized by Pseudomonas. So inhaled tobramycin is kind of the first line treatment. If they're chronically infected with Pseudomonas, typically they'll get chronic azithromycin for about 18 months because Pseudomonas is kind of known to accelerate loss of pulmonary function and decrease survival. Typically, you'll continue the therapy for 18 months before retesting for Pseudomonas, and then some of the literature recommends testing for non-tuberculosis mycobacteria at 6-month intervals due to concern for resistance. Other antibiotics are typically reserved for acute exacerbations, but they do recommend sputum cultures every 3 months as part of routine care. And just some additional therapies. So our patient was taking Pulmozyme. That's an inhaled airway clearance agent. It's inhaled Dornase alpha. Many patients will also take like hypertonic solution, and the goal of these medications is to break down thickened secretions within the lungs. They must be used in conjunction with kind of airway cleaning therapy. So I'm sure we've all seen those babies with those like vests where they're shaking them. So that's what those are for. And then very rarely will people now be on chronic steroids. This is typically only reserved for CF patients will also meet criteria for asthma. Is just because there's been insufficient benefit in CF patients without asthma, and there's an increased risk for impaired longitudinal growth, particularly when they're given in children. And so now thinking about pregnancy. So prior to pregnancy, there's certain things that we should be considering. So certainly like our patient had her partner CF mutation testing, and the recommendation is for next generation sequencing of the whole gene as opposed to just screening, because the standard screen will miss up to 30% of affected pregnancies. We want to make sure they have a recent pulmonary function assessment, because women with a decreased pulmonary function, so an FEV1 less than 60, has been associated with worse maternal and neonatal outcomes, including preterm delivery, C-section, growth restriction. And typically they would advise against pregnancy if FEV1 is less than 50%. A normal FEV1 is like 70% in all of us, so something to consider. And then you want to have an idea of kind of what respiratory pathogens they've been colonized with. So many will be colonized with Pseudomonas, which is typically well tolerated during pregnancy. But women who are colonized with Burkholderia are particularly susceptible to having lung deterioration during pregnancy. You want to maximize their nutrition, make sure they've had their vitamin levels checked recently, make sure that they're at an adequate weight, and then you want to make sure they have an established collaborative care, both with MFM, who will probably be managing the pregnancy and guiding care there, but also with their pulmonologist, endocrinologist, or GI if they have those symptoms. And so just some goals to think about, like I said, optimizing lung function. So when FEV1 is greater than 60%, several studies have found that there's no difference in decline in lung function in CF patients who get pregnant and kind of CF patients who are not pregnant. And there's no difference in long-term survival. You want to make sure their BMI is above 22. That's kind of the goal, because we know there's certainly many associated risks with pregnancy for someone who's malnourished or has a lower BMI. And then in thinking about their vitamin supplementation, all of them are safe in pregnancy, even the vitamin A. The one thing that they note was if they're getting more than 25,000 international units per day of vitamin A, you may want to think about decreasing that supplementation because of the risk of teratogenicity. And then if they haven't had any recent glucose testing, you want to make sure that they have at least a 2-hour glucose tolerance test prior to pregnancy. If they have diabetes related to cystic fibrosis, you want to make sure their A1C is less than 6.5%. And then you want to make sure they have adequate vitamin levels and iron levels. During pregnancy, they should have visits with their CF team at least every trimester to do pulmonary function testing and manage their weight. You want to aggressively manage nausea in the first trimester, particularly for patients who may be underweight or who may be more susceptible to like electrolyte abnormalities and issues with that. You want to minimize constipation because of the risk of ileus and gastroparesis, and then you want to make sure they have adequate weight gain. You may want to consider like enteroparental nutrition if they're not gaining weight or if they're persistently underweight. And then if they don't have diabetes prior to pregnancy, you also want to do early glucose screening like we would for other people with risk factors for diabetes. So typically like once in the first trimester and again in the third trimester like we do for most patients. And then as we all probably know, there's no you would only do C-sections for obstetrical reasons. There's no reasons for like an iatrogenic preterm delivery, although we do know that women with worse pulmonary function are at increased risk for C-section. In thinking about the medications that they typically kind of take for their maintenance therapy, all of them are pretty safe in pregnancy and in lactation. The one caveat is obviously those CFTR modulators. As with most medications, no pregnant women were included in the clinical trials for those. So most of the data that we have on their safety is from animal models. In a couple of the animal models, they showed an increased risk of infant cataracts in like the rat models for rats that were exposed to this medication while pregnant. A lot of the literature in like adults hasn't shown those same findings, but most of those are based off of like case series and registry studies. But they're generally thought to be well tolerated and safe in pregnancy and breastfeeding. For kind of acute exacerbations, all of the standard antibiotics that we would use are safe. You're typically going to be targeting Pseudomonas and MRSA and MSSA. The only ones we would obviously avoid are fluoroquinolones and aminoglycosides, but certainly if it's a risk of like maternal like health and death, you may want to consider those. And then postpartum, some literature says that you may want to do infant LFT monitoring because of the risk of transaminitis related to CFTR modulators, and then infant cataract monitoring, and then they should have ideally close follow-up after delivery with their CF team to monitor their pulmonary function and BMI, ideally within the first month postpartum. I just wanted to look at some of the pregnancy outcomes in cystic fibrosis patients who get pregnant. So prior to kind of widespread CFTR modulator use, there's been a couple registry studies. The first was an Italian registry of 56 pregnancies. They had a mean pregnancy duration of 37 weeks, and about 37% required a C-section. They said that was like an increased need for C-section. I would argue that's probably our C-section right here at Jefferson. So it's probably the same. With the second study, it was 66 pregnancies in the UK registry, and they had a mean pregnancy duration of 36 weeks. They noted that patients with a FE1 less than 60% were at higher risk for preterm delivery and low birth weight, which the first study, the Padua study, also said a lower FEV1 was associated with the increased risk for prematurity. Since more widespread CFTR modulator use, there's been a couple registry studies as well. So the NASH study was 64 pregnancies, of which 44 continued their CFTR modulator during pregnancy. And of the 20 patients who kind of stopped their therapy, 9 reported a clinical decline in respiratory function and eventually restarted their CFTR during the pregnancy. And they didn't report any sort of adverse events and no increased risk of fetal anomaly. There's no reported cases of infant cataracts. And then Taylor Kusar, which is I think a doctor over at UPenn, did another large study looking at, or not large, another study looking at 46 pregnancies, of which 45 continued their Trikafta or that triple ETI for all or part of their pregnancy. They only had one maternal complication that they attributed to the medication, which was one mom develops cholecystitis and required a cholecystectomy. And then in this study, there was no cases of infant cataracts or any sort of infant complications related to the medication. And then Dr. Wren, our colleague at CHOP, actually sent these over last night. And they're now even using these CFTR modulators for fetal therapy for fetuses that are diagnosed with cystic fibrosis. So these are just 2 cases. The first was in 2021, which was a patient who had cystic fibrosis and had a fetus with the F508 homogeneous mutation. And so she was actually on Trikafta before pregnancy, continued it for the duration of her pregnancy. And this infant, despite having that was homozygous for the F508 deletion, was born with normal pancreatic function, and the CF was undetectable on a newborn screen.
So Trikafta crosses the placenta, or do you have?
Okay. And the second patient was a CF carrier who ended up having a F508 deletion homozygous fetus. And so the fetus's cystic fibrosis was diagnosed at 18 weeks. They noted meconium ileus to develop by about 23 weeks. And so would share decision-making between her MFM team, their CF team at the institution. They decided to start the patient on Trikafta at 32 weeks. They did note that meconium ileus persisted in utero at assessments at 33, 35, and 36 weeks. She went into spontaneous labor at about 36 weeks, and after delivery, the infant passed meconium. It had multiple stools. There's no evidence of meconium ileus after delivery, which is pretty remarkable. The infant did test positive on the newborn screen for cystic fibrosis, though. And I think while we're probably going to be seeing a lot more pregnant patients who are coming in on these CFTR modulators, we may see CF patients who have had lung transplantation, who are trying to get pregnant or desiring to get pregnant. It's important to kind of counsel them that they're at higher risk for maternal and fetal complications. There is higher risk for preterm delivery and growth restriction related to kind of their comorbidities, so their lung function, their malnutrition. There's an increased risk of graft rejection, so the recommendation is to avoid pregnancy for at least 2 years after transplant. There are certain immunosuppressants that we should be avoiding, like mycophenolate mofetil, because of their risk of teratogenicity. And then you want to closely titrate the dose of their immunosuppressants because most of them are weight-based. There was a study looking at kind of pregnancy outcomes in the National Transplant Pregnant Registry, and they looked at 36 lung transplant recipients. And unfortunately, 9 patients died and 2 reported reduced lung function following pregnancy within 5 years of delivery. So certainly they certainly can get pregnant. Like most CF patients, we want to optimize their health prior to getting pregnant, but these may be patients where we're considering kind of surrogacy or adoption as well. So just to conclude, I think with the introduction of CFTR modulators, there's been a huge decrease in the mortality and morbidity of cystic fibrosis. As they become more widespread, I'm sure we'll be taking care of more pregnant patients with cystic fibrosis. They've been saying that like now they're even finding like CF patients with like obesity for the first time because their health is like so well controlled on these CFTR modulators. And while the studies are reassuring so far about kind of their use in pregnancy and in the postpartum period, they continue to be ongoing, and we still need more safety and efficacy data, as well as like long-term outcomes. There is a study being done at Penn called the Mayflower study that's enrolling patients right now for pregnancy outcomes and fetal outcomes if they're on CFTR modulator. For our patient, I think she had been in contact with them, but she didn't want to get prenatal care with them, so she couldn't participate. But the studies are out there.
I can't believe they wouldn't want to collect information even on people who are not at their site. Maybe they
Yeah,
have
I mean, I
one.
contacted them. They didn't even get back to me, actually. I'm still waiting to hear back from them because we were saying like we can just order whatever labs they want.
Right, exactly.
It's a national study.
Yeah, that's what's weird
Yeah.
too.
Yeah.
So these are the references, and now I'm happy to take questions.
Yeah, I had a patient last year who breastfed like both her children on Trikafta and had no issues. And she came to us, it was her second pregnancy. And I think your point about like nausea and vomiting is so important. She had like her first pregnancy, she had lost an insane amount of weight, and it was during COVID, and basically was like starving.
She's the one who's at Abington for a while.
Her name is Stephanie. Her husband, her notable thing is her husband's an ortho.
Oh, that's what it was. Yeah.
Yeah.
Would you like to
Did
really?
we have a patient who was getting treated for fetal therapy?
Yeah.
What happened with her?
Be transferred to CHOP.
Yeah, Alexa, I don't know if I don't know.
Oh, I didn't. Okay.
But I know that's why Dr. Wren sent over those studies because he's managing her Trikafta treatment for the fetal therapy. Alexa, I'm not sure if you're on, you can speak to how her case is going.
And that's adult dosing.
Yeah.
You just give adult dosing.
Yeah, you have adult dosing.
I haven't heard since she transferred over, which wasn't that long ago.
Yeah, I didn't realize she had transferred over.
Yeah, that was, I think they wanted to start managing her there after like 28 weeks or something. Dr. Wren also said, we asked Dr. Wren if he could be on the talk this morning, and he just wasn't able to do it this morning, but he said he'd be happy to give a talk to your group, to you guys, if somebody wanted to reach out to him and plan that. But
Yeah, I'll reach out to him. That's great.
sure, thanks.
What you're talking about, like with oral secretions and upper airway stuff, would you do an early anesthesia consult for patients with CF who are pregnant?
I think it would be kind of how bad their symptoms are. So like the patient we have right now, she has like no, like with all of her medications, she has no issues with that. So I don't think like airway management would be an issue for her.
Like under normal circumstances, it's more challenging airway than a non-pregnant patient. So imagining that CF doesn't help matters.
I know that. I saw Jen saw her for her first pregnancy when she had her miscarriage.
Oh, I did.
Keely saw her for preconception counseling, and then I saw her for this. I don't think we recommended an anesthesia consult any of the consults. So.
Thanks, Neil. That was great. I think
Amanda,
I'm
we
up.
can't hear you. I know Amanda was her mouth was moving, but your speaker's not working. Sorry, Rich, I didn't mean to interrupt you. No, we can't hear you, Amanda. We see your mouth moving. Sometimes one of the speakers in that workroom, one of the
That
computers.
particular computer's a bad one. Go to the other ones and they usually have sound.
Go ahead, Ripsha, sorry.
That's okay. I was just gonna jump into the next lecture, which is gonna be SPSS, if that's okay.
Updates from the ICN. I think Dr.
Oh.
Sloan's on.
Thank you. Yes, go ahead.
Sure. Hi, good morning. I'm Amy Sloan. For those of you I haven't met, I'm the newest ICN attending. I just have just a couple babies for our fetal list. Baby Talzol, I presented at OBCC last week. She's on our list, but went home about 2 weeks ago. This is a 29-weeker who did very well. The baby